All right, so today, my name is Emma. Let's start with that. If you're a medical student, I'm nearing graduation. And today we're going to talk about the kidney a little bit. It's kind of a loaded topic, so we're going to kind of simplify it as much as we can. And what we're talking about is acute kidney injury. And it's kind of a nephrology-based topic, an internal medicine topic, and it kind of combines multiple things. And today's case is kind of unique because it's going to talk about some kidney things, yes, but it's some cardiac things as well. So we're going to see kind of a full picture internal medicine case today, my favorite, basically. So let's keep going. But first, I'm going to launch this poll for you guys. So use a couple seconds to just kind of gauge, or for me to gauge your understanding of acute kidney injury. All right, so we will stop there. Let me share the results. And it looks like a lot of you guys said you either know nothing or you know a little, and that's totally okay. Acute kidney injury is kind of a complex topic, and probably your guys' knowledge is maybe about CKD or other kinds of kidney problems, and that's okay. We're going to kind of incorporate a little bit of renal anatomy, a little bit of renal physiology, all of those things. But let me stop that sharing and let's keep going here. Okay, so what are we going to do today? I just realized as I brought up the slide that this is wrong. This is the outline from the last time. We're doing one case today, and then we're going to sort of talk about the pathology afterwards. And then what is your guys' role? Your guys' role is to read the cases, kind of participate. You can always unmute yourself. You can always type in the chat, whatever works best for you. And then fill out the SOAP note throughout the entire presentation. I just put the link in the chat. If you click on that link and go into today's date, which is the 2nd, we are talking about acute kidney injury. And then you can kind of go through and fill out that SOAP note. It should be a little bit easier with this week's presentation, primarily because we have one case. So there's a lot more of the objective findings. We're going to talk about physical exam findings. We're going to talk about the assessment and plan and kind of go through all of those things. So you should have good exposure to kind of a full SOAP note this week. And if you have any questions about that, just let me know. And you might be who is this character right here to the right with the dirt on his nose. That is actually our foster dog. You guys might have heard a similar story last week if you were with us. And this picture was actually taken when I was working on these slides, and he wandered off in the backyard somewhere and got dirt on his nose and came back. It turned out to be a really good photo, so I figured I would share it with you guys. But let me clear this and let's keep going. All right, so here's this. What we're going to kind of talk about today. Oops, didn't mean to do that. All right, what we're going to kind of go through today is a few things. So first, what we're going to focus on is the subjective part, which is the S of SOAP. And what we're kind of going to emphasize in the subjective portion of our note is the HPI, which is things that the patient tells us that kind of gives a narrative of why they're there that day. And then the ROS, which is pertinent positives and negatives related to the chief complaint. So if somebody comes in with belly pain, we might ask them if they have a fever or nausea, vomiting, diarrhea, things like that. The objective portion is things that we find. So things like vital signs and things like the physical exam, which you guys will get full exposure to today. And then the A is for assessment and the P is for plan. And the way that I typically rate my assessment and plan is I'll say, we are writing the note and the patient has abdominal pain and it's in the left lower quadrant. We might say likely diverticulitis, we'll get CT, abdomen, and pelvis to rule out, or something like this, where we're kind of saying what it is, and then we're giving kind of what we would do, which is the plan, okay? Or say, for another example would be diabetes. And we will put, if it's uncontrolled, say their A1C is 10, we'll say uncontrolled. And then our plan of what we're gonna do to it, add additional medication or increased dosage or whatever we're doing at that time. Okay, I hope that makes a little more sense in terms of assessment and plan. With our rapid cases, we hadn't really seen a lot of that, but we're going to focus on that a little more today. Okay. All right, let's keep going. First things first, we're going to talk some anatomy, and we're going to focus on the image that's on the left-hand side first. Okay. Through this and kind of talk anatomy and talk about kind of pertinent anatomy. First, starting with the ureter, and you guys are probably familiar with the ureters, and when we think of kind of the kidneys, we think of those, you know, kidney shaped things that kind of have the ureters that go down to the bladder, and that's probably, it may be the extent of what you know, and that's totally okay. That's fine with me. We're going to kind of go through that anatomy right now, and we're going to really keep it simple because there's a lot to kind of do with it. Other than that, we're going to look at here's the renal artery. The renal artery will supply blood to the kidney while the renal vein will take blood away. The renal artery is a branch of the abdominal aorta. So if we saw this in kind of full context, what we would see of the abdominal aorta here, and then we would see a branch, and it's a little bit distal to the superior mesenteric artery, which is a big artery that supplies part of the gut. And then other than this, we're going to really kind of focus on two different parts. So when we look at the kidney and its kind of anatomy, we look at two things. We look at the cortex, and then we look at the medulla. So here's the medulla. And let me kind of get rid of some of this stuff because it's starting to get crazy. All right, so the cortex and the medulla. And when we look at the medulla, we kind of focus on these little objects here. These look like kind of star pyramids, or within the medulla are the pyramids. And that's what this image kind of in the bottom right-hand corner is showing us. It's showing us kind of within the pyramids of the neck, which is by definition the basic functional unit of the kidney. And I always thought it was kind of funny to think of this kind of structure in the kidney. And there's a lot of them. There's millions of nephrons in the kidney, or in the human body total. And these are the basic functional units. And on the next slide, we're going to learn a little bit more about really what's going on in this and why they're really deemed the functional unit. But to kind of keep it simple here, there's a few parts that we're going to focus on. So glomerulus, and here we have the afferent arteriole, that's the one coming in. And then on the other side, we have the efferent arteriole. The way I always remember that is E for exit, and then the other one is the other one. If you keep it simple, you'll remember a lot more things and not just remembering, just memorizing. So if you know the efferent is the exiting one, then the other one by definition is the afferent arteriole, okay? And that does a lot of the basic filtration initially. And then we're going to progress along the nephron to the proximal convoluted tubule. And we're going to see there's a lot of things, a lot of metabolites absorbed there. Then remember, we see out here our cortex, and then out here we see our medulla. And it kind of gives you that color change here to show you that. And then we're going to go down. This is our descending loop of Henle. We're going to see primarily water is reabsorbed there. And then our ascending tubule, we're going to see three things primarily that are reabsorbed there: sodium, potassium, and chloride. And we'll talk about the importance of that later. Then later, here's our distal convoluted tubule. And that's primarily where sodium and chloride are reabsorbed. And then down here, when we progress to the collecting duct, that's where a lot of the final resorption of water takes place. And then finally, that ultrafiltrate turns into urine. And we don't call it urine technically until it is in the actual ureter going to the bladder. And the bladder is essentially just a storage mechanism for that ultrafiltrate, for that urine. Okay, so that's a little bit of the anatomy there and kind of keeping it simple. Do you guys know which kidney in the body? Yeah. Do you know which kidney is technically lower in the body?
Would that be the left kidney?
So technically, it would be the right, because the liver is on the right side. So the liver is sitting there, and because of that, it kind of pushes it down a little bit. All right.
Okay.
So let's keep going here. Let's talk a little bit of physiology. And if I cut out again or you guys can't hear something, just let me know. So here's the physiology. And when we talk about kidneys, that's the bulk of kind of kidney is physiology, and everybody hates it, but I kind of like it, admittedly. So when we talk about the functions of the kidney, what we're really kind of focused is we're talking about the formation of urine, which we kind of touched on already, but we're also talking about other things like hormone secretion, acid-base balance in combination to the lung. And then also talking about the balance of the osmolality of the actual serum of the blood. And then also blood pressure regulation, which I think everybody forgets about the kidney being involved in that. And then some of the first questions, that a lot of providers ask, I know I certainly do, when somebody has high blood pressure that's not controlled with a lot of medications is, are you taking NSAIDs often? Because NSAIDs will kind of constrict the afferent arteriole and cause an issue in that regard. Okay, so in terms of the formation of urine, we see a few things being reabsorbed here. And then if we look at this kind of figure here in the kind of middle, or actually, let's focus on the one on the right first, because that kind of touches on a few things that I want to talk about in terms of what the kidney is actually doing. And in terms of the formation of urine. And that's kind of these functions over here. And number one, what it does is filtration. So Bowman's capsule is kind of this little yellow guy here, and then here's the glomerulus right here. And what we're doing is kind of filtering that blood, and it's going across a membrane here, and that's the process of filtration, to kind of keep it simple. Then we kind of have reabsorption, where things are kind of reabsorbed from nephron to the peritubular capillaries. Then the process of secretion is when it goes back from the peritubular capillaries to the actual nephron. And then excretion, where it's finally excreted at the end. So that's kind of the process that we look at in terms of the formation of urine. But what are we really talking about when we are talking about all these things kind of together? What we're really looking at is what's in this middle diagram here. And then pointer again. All right, so in the middle diagram, if you remember, what is this part right here? What is this going? Compares to another on the right. but it's in the sort of filtration of urine. Yes, exactly. It's the glomerulus. And whenever I used to draw it in my notes, I used to draw it exactly like that. And it kind of looks like that because it's, really kind of a bundle of different arteries and capillaries that kind of form the glomerulus and kind of function in that filtration process. So now let me get rid of this. All right. So what we're focusing on now is this area right here. And do you guys remember what this aspect is called? This part. That is called the proximal convoluted tubule. And if you kind of think of it, it makes sense. It's most proximal to the glomerulus. And what that does is it really kind of functions in the reabsorption of a few electrolytes. So things like glucose are here. And when the glucose transporters are saturated, which is usually around like the 360 or so mark, when that's saturated, then we get glucosuria, which is glucose in the urine. So that's a great clinical clue for us in terms of diabetes when sugar is kind of spilling over into the urine. Other than that, we have things like amino acids, vitamins, lactate, and urea and uric acid, all reabsorbed here, along with a few other things. These are kind of things that can be reabsorbed in other places. Calcium is primarily in the proximal convoluted tubule, and bicarb is an important one here. So glucose, calcium, and bicarb are important, and then some of the other ones are reabsorbed in other places. For instance, you'll see sodium throughout the nephron. You'll see it here. You'll see it in the ascending loop, and then again here as well. So the other part that we're going to kind of focus on is, yes, there are some things reabsorbed here, but we're going to focus on the descending loop of Henle, which is this part here. And we'll see that on the descending loop of Henle, we see the passive transport of water. And pay attention to that. For those of you that fell asleep or weren't listening, passive transport of water happens in the descending loop of Henle. That may or may not be a quiz question later. Then you get up to the ascending loop, and we see that three things are reabsorbed here, which is sodium, potassium, and chloride. And when we focus on these things, what we're seeing is, do you guys know of any drugs for blood pressure and for some other uses that are that inhibit that transporter? It's okay if you don't. It's kind of a tough question. Not vasopressin. Vasopressin will kind of work over here in the collecting ducts. Yeah. So actually, it's going to be loop diuretics. So we know those are our loop diuretics. So they work on the sense, so it kind of blocks here. And then our thiazide diuretics, like hydrochlorothiazide, work over here. So this is kind of a clinical thing. It's nice when those things kind of line up. So the thiazide diuretics work here, and they primarily block sodium and chloride, and that will correspondingly block your blood pressure, because we know if we're not reabsorbing sodium, water's not following it. So we get that decrease in blood volume and correspondingly decreased blood pressure. And then lisinopril is another one that's an ACE inhibitor, and we'll see in a second where that works. But let's keep going here. And then obviously down here, we get some more reabsorption of water and urea, primarily in the collecting. Okay. But does the glomerulus just mean a bundle of parts? Basically, yeah. Yeah, so the glomerulus is kind of basically it's a bundle of capillaries, more or less, that kind of is involved in the filtration of the blood in order to kind of extract all of those metabolites that allow us to form urine and basically that waste product. All right, let's keep going. I have one more slide to kind of talk about blood pressure regulation because it is very important before we kind of go on to our case, which is to talk about, you guys talked about ACE inhibitors or brought that up. And then when we talk about blood pressure regulation, what we're talking about is kind of the stimulus for these hormones to be released. So if we talk about dehydration, we know that there's a decrease in blood volume. And when there's a decrease in blood volume, we get a decrease in blood pressure. And when that happens, the juxtaglomerular cells of the kidney, important cells of the kidney, those are located primarily near the glomerulus. And when that happens, we get renin. That's our friend renin here. And simultaneously, the liver's producing angiotensinogen, and renin is a cofactor for the conversion of angiotensinogen to angiotensin 1. Okay, that's what we see here. Then from the lungs, we see angiotensin converting enzyme, which is very appropriately named. And sometimes, not all things in medicine are appropriately named, but this is one of those that actually is. And that's going to help the conversion from angiotensin 1 to angiotensin 2. And from there, what we're seeing is angiotensin 2 that kind of helps us in the vasoconstriction of the arterioles, but also as a stimulus for the release of aldosterone from the adrenal cortex. And if you remember our kidneys, here's an ugly version of a kidney. On top of the kidneys, the kind of fat hat on the kidney is our friend, the adrenal glands. And they're pretty important, and we can have a whole talk about adrenal glands all on their own, but they release aldosterone, and aldosterone saves sodium. And if you put that into a mnemonic, it is always the way that I had remember it. Aldosterone saves sodium, and that's going to increase the blood pressure is kind of the end stimulus of all of these things together, is aldosterone, and then kind of the release of 3 different things from 3 different organs, from the kidney, from the liver, and then from the lungs, kind of work all together to increase the blood volume, to increase the blood pressure. Okay, so I wanted to introduce that to you briefly because we always talk about hypertension, but that's kind of the mechanism behind why it happens. And then to briefly touch on the hormone secretion, that's what we're talking about here. We're talking about renin, we're talking about EPO. EPO is a stimulus for the production of red blood cells. Then acid base. In addition to the lungs, we know that the kidney controls acid base balance. So things like reabsorption of bicarb, which is a base. You guys probably know that from chemistry. And secretion of hydrogen ions, which is an acid. So there's your acid-base balance. And then we also have osmolality regulation by reabsorption or secretion of sodium, which is a osmotic agent or a metabolite that can kind of alter the osmolality of the blood. Okay. So let's keep going here. And let's talk a little bit about AKI before we go into this case, because I want you to kind of know a little bit before going in blind. And talk about AKI, what we're talking about is basically three different types of acute kidney injury. Okay. Pre-renal. And when we talk about pre-renal, we want to think of all the things that have decreased blood volume. That's what I want you to remember. When I say pre-renal, that was a horrible B. When I say pre-renal, I want you to think decreased blood volume. So things like decreased cardiac output, absolutely, that's decreased blood volume. It's causing basically a essentially in a hypovolemia for the body, because what's happening is the kidney is not getting the blood that it needs. It thinks it's hypovolemic and gets injured as a result. Other things, decrease effective circulating volume. So this kind of goes in line, decreased cardiac output with heart failure, and also with liver failure, because you're kind of third spacing all of that volume. And then impaired autoregulation of the kidney. So drugs can certainly cause that, like ACEs and ARBs and enzymes. Then the next one that we're going to kind of focus on is intrinsic. And when we think intrinsic, I want you to think two things specifically. And yes, there are all these etiologies, things like acute tubular necrosis, ATN. We're not going to focus on that today, but that is a cause of kidney injury or a different type of kidney injury. But I want you to think of two things. When I say intrinsic, you guys say ischemia and basically drugs like nephrotoxins, things like contrast dyes, things like volume, things like exposure to proteins and multiple myeloma, things like aminoglycosides, which is an antibiotic, different like that. So that's going to cause the kidney to get injured because there is either ischemia or exposure to drugs. And then finally, the last one is post-renal. And the one I want you to think about in terms of post-renal is obstruction. So things like BPH, benign prostatic hyperplasia. We see that often as a cause of post-renal problems that kind of backs up to the kidney. If we have, the prostate obviously runs directly through the urethra. And if we have a problem with that, urine kind of backs up, we can get a problem with the kidney as a result. Okay, so very simple. Just to kind of recap, when think pre-renal, we think of a decreased blood volume, a hypovolemic state. Intrinsic, we want to think about ischemia, and we also want to think about nephrotoxins. And then finally, with post-renal, we want to think about bladder outlet obstruction. Okay, let me clear all this and let's keep going. Oh, just to kind of touch on this image in the upper right before I forget, we're going to focus primarily today on the FENA, the fractional excretion of sodium. And the two things that we're going to use today, I'm going to show you how to calculate this, is we're going to differentiate pre-renal and renal using the FENA. And when it's a pre-renal etiology, usually that FENA is less than 1. And when it's a renal cause, usually, and the way I remember that is the kidney has issues when it's an intrinsic renal problem, and it has damage due to ischemia or nephrotoxins, and it kind of dumps all the sodium. That's how I remember it. And then with pre-renal, you get that kind of hypovolemic state, but you still have intrinsic function of the kidney. So keep those in mind, keep these in mind. These are going to be test questions for sure. And remember, pre-renal is less than 1% for FENA, fractional excretion of sodium, and then renal, it's greater than 2. Okay, let me clear all this. And finally, let's get to our case. And let's have somebody read the case, if you will.
A 66-year-old man with a PMA significant for HTN presents for a 4-day history of shortness of breath. He knows that he has been short of breath and walking and attempting to dress himself in the morning. Also, he has noticed his feet have been more swollen despite limiting fluids and elevating his feet for 4 hours after work each day. The patient also describes fatigue and mild weight gain, denies chest pain, dizziness, or syncope. His fast person for the injury and states the patient has been snoring at night and sleeping on the living room recliner. Since he's severely short of breath upon laying flat at night, he sometimes awakens and feels the need to step outside for fresh air due to a shortness of breath. He takes amlodipine for hypertensive management and denies other medication, alcohol, or drug use.
Perfect. Thank you very much for reading that.
You're welcome.
And we have a few things to talk about here. So obviously I was feeling kind and I bolded the things that are important that you guys should kind of keep your eye on here. But a few things that I want to kind of draw your attention to otherwise is this thing right here. He is sleeping on the living room recliner. Does anyone know what that's called? Sometimes we relate it to pillows. And if you guys have been to my original talk on congestive heart failure, this whole case may be reminiscent. And if you haven't, then this is brand new to you. But we talked a little bit about it then, what that's called. But that is called orthopnea. And sometimes we'll say, you know, are you sleeping on a recliner, or how many pillows are you using at night? And sometimes we'll write it in our charts as 4-pillow orthopnea. And that just is telling us that there's this fluid kind of inhibiting their breathing, essentially. And the other thing is this. And this is PND. It's called paroxysmal nocturnal dyspnea. And that's kind of that sensation of where you're very short of breath and you have to get outside for fresh air. So we're going to keep going here. And I want you to keep all of these things in mind, including the shortness of breath, him not being able to dress himself in the morning, his feet being swollen, having weight gain, being and he is taking amlodipine, which we know is a calcium channel blocker, but can contribute to legs being swollen. So we have to kind of discern what's going on here. Is the leg swelling because of the amlodipine? Is it because of something else? We want to have a differential in our head. Okay. So let's keep going. And here is our physical exam findings. We see in this image on the left, we push this guy's anterior shins, and we see what would we call this physical exam finding? Awesome. We would call it pitting edema. And because that has a pit in it on the right side and it's not coming back up, and they had an opportunity to take a picture, I would say it's pretty significant, at least 2+, maybe 3+ pitting edema. And when we grade the pitting edema, we say how high it goes, and it's on a scale of, you know, we can just say pitting edema 1+, 2+, 3+. And then on the right, does anyone know what this is called? Yeah, it's JVD. Good. So it's called jugular venous distension. And we can see some JVD usually in different etiologies. We're going to talk about all of these things. We can see it in cardiac tamponade. We can see it in pulmonary causes. We can see it in heart failure. So it's not kind of see JVD, think this kind of thing. It can be caused by multiple things. So we want to keep a lot of things on our differential still. All right, the rest of our physical exam, we see the patient is tachycardic at 114. Is this blood pressure high, low, or normal? Yeah, it's low. Probably for both systolic and diastolic flow. The patient's lethargic, but has moist mucous membranes, tachycardic. Does have an elevated JVP, some diffuse crackles we heard on the lower lobes, and then we hear some expiratory wheezes. So there is some pulmonary stuff that sounds like going on here, or at least fluid overload, especially with the JVD. And then we have some tenderness to palpation. It looks like in the right upper quadrant. We have some hepatomegaly going here, and then no splenomegaly, and then 3+ pitting edema to bilaterals to the mid shin. So that's how we would write it out. We said 3+ to mid shin. Okay, that's where it extends up to. But we would kind of press all the way up to kind of the knee. See, sometimes it even goes all the way up to the thigh if it's pretty bad. But here's our physical exam finding. And now I'm going to have some questions for you guys. And I know that you guys probably have some good ideas in your head. But here's some labs. We're going to kind of go through them together. First things first, let's focus on the BMP over here. And that's what this is kind of showing you. If you're unsure of what these fish diagrams mean, that's totally okay. And over here, we see a low sodium. We see a low potassium. We see a low CO2. And then of kind of concern, we see a high BUN, and then we see a high creatinine. So what does that point us in the direction of? High BUN, high creatinine.
I'd say kidney failure, like kidney damage.
Yeah, perfect. And if we're kind of looking in the context of this BNP, we're looking at BNP now, not BMP like basic metabolic panel, but a brain natriuretic peptide. What does the brain natriuretic peptide actually tell us? Or what organ does it kind of point to? Yeah, it points to the heart, good. And we know that brain natriuretic peptide is released from the ventricles when there is a certain amount of stretch. And it could be stretched because of multiple reasons. But we have a low GFR also. So all of these things are pointing us in the direction of what do you guys kind of have in your head as a differential for this patient? Good. Yes, Destiny, I agree with you. I think there is some sort of etiology of heart failure going on. That's something that we want to keep on our differential. Anybody else have any differentials? I love having a long list of differentials because you know what that means? It means we're not ruling or we're not leaving anything out. We're not missing anything. So what else do we think is going on? Do we think that the problems with the kidney are because of the heart or vice versa? Good. So pre-renal AKI, I agree with you, Madeline. Madeline definitely paid attention to the intro. Good. Respiratory problems because of wheezing, sure. We definitely want to rule that out. Excellent. Anything else that you guys are thinking of? If you were with our talk last week about chest pain, what's something that we would want to think about as an acute cause of chest pain that is a respiratory issue? Yeah, certainly hypoxia, definitely, especially in the context of a pre-renal AKI and hypovolemia. What if enlarged liver? Good, yes. Excellent. History of drinking or smoking? Good. We definitely want to ask that. COPD, we can consider that as well. Definitely. All right, so what testing do you guys want to get for this guy? You're kind of a blank slate here. I'm your attending. I'm telling you, all right, order what you want. Let's see if we can't get to the bottom of it. So you guys are in control. EKG, chest X-ray, good. Chest X-ray, excellent. I did originally have an EKG on this and I took it out, so I didn't talk too much. So I'm not showing you an EKG today, but I'm definitely showing you a chest X-ray. Anything else?
What about a CBC to like rule out any like blood issues? Because maybe that could be a sign of like any kidney or heart issues, and maybe
Yes.
a nephrology exam.
Yes, definitely. I agree. CBC, that's right here. You ask and you shall receive. So it's it's all normal basically. And we would maybe want to look at things like anemia, but this guy has a fairly normal, fairly benign CBC. UA, good. What do we want to look at for the UA? Stress test. We certainly can, but if this patient's pretty sick, we're not going to be able to get him up on the treadmill. So Madison, instead of a stress test, what might we do if this patient's pretty sick and we want to look at the heart other than an EKG? We can look at, we can look at glucose and we can look at WBCs. Yeah, good, Madeline. Madeline kind of finished Madison's thought there. Yeah, we definitely want to look at an echo. The good thing about medicine now is if you kind of have a bedside ultrasound, a point of care ultrasound, you can kind of put it on the heart and look and see what roughly the ejection fraction is of the heart. That points us in the direction of if this is heart failure with reduced ejection fraction. Yeah, it's the Maddie collab. You guys should start a podcast. Awesome. You guys are right on track. And with that, let's go on to the next slide. So here's our chest X-ray, and it's hard, and I know it. But tell me what you guys see. And if you were with us next week or last week, sorry, remember our mnemonic A, B, C, D, E. So A is for airway, B is for bones, C is for cardiac, D is for diaphragm, E is for everything else, which is kind of a cop out. So enlarged heart, yes, Seema, I absolutely agree. Very good.
Fluid.
What's that?
I see the diaphragm, but I do see some fluid. So the heart seems a bit enlarged and like it's filled with fluid.
Yeah. So yeah, definitely. Yes, I agree with that. So the heart should be about giving you guys too many clues. The heart should be about 2/3 the size of the kind of mediastinum, and this is a little bit bigger than that, and that's cause for concern. So here's the heart. It's kind of enlarged. We don't see any fluid kind of in the costophrenic angles, and there could be, but it's not obscuring it. And what we really need there is about like 300 milliliters of fluid to kind of obscure that costophrenic angle here and kind of fill that up. But we don't see that. And what we're kind of seeing is kind of these lines here. We're going to talk about that in a second. We see some here, and then we're seeing some of this like prominent vasculature here. We're going to talk about that as well. But if we start from the top with that mnemonic airway, we kind of look at the trachea and say, okay, is this midline? Great. We can see a really good kind of carina here and kind of the split of the left and the right main stem bronchus, which is kind of cool. Now, you don't always get to see that. Here's the aortic knob. That looks fairly normal. And then we look at cardiac. We kind of talked about the heart a little bit. And then we also see the diaphragm. We talked about that, and then everything else. So I'm looking at this. Here's the left, obviously. Do you guys think this is an AP or a PA? So anterior to posterior, so it's shot from the chest, in front of the chest to the back, or posterior to anterior, so from the back to the front.
AMP, AP, anterior to posterior.
Yeah, I agree with you. I do think it is a anterior posterior, and we have to be careful in that regard too, because if we think the heart's big, we have to know what kind of image this is. And this one actually might be a PA. I'm not entirely sure. It's kind of obscured here, and it kind of looks like a AP in that regard, but or a PA. I'm sorry, but we have to be careful when we say that the heart is enlarged. Long story short, I'm not actually sure if this is an AP or a PA. You know, this one is obviously a lateral. We all know that for certain, but I think this actually might be a PA. And I took this so long ago, I'm not entirely sure, but I think it is a posterior to anterior because the clavicles are here in the front. We see kind of some of the vertebrae there, and then yeah, I'm pretty sure that's right, but don't quote me. All right, let's keep going. Nothing too special on the lateral there. We see that the heart's ginormous, but let's talk about this. And when we're talking about this, we're going to kind of point out a few things here that are important. The first of which is kind of this hazy contour of the vessels. We talked about that. And then we saw a cephalization of the pulmonary veins. So kind of fuzzy obscuring of the pulmonary veins there. And then those little lines that we talked about, you can kind of see them here, and I'm not going to draw them in because then it's going to obscure them. But those are called curly B lines, and it's not Cardi B lines. They're curly B lines. But I always think of Cardi B when I hear curly B. They were called curly B before Cardi B was even a person, but I'm pretty sure a person, but at least before she was famous. But anyway, the heart is definitely enlarged. We call that cardiomegaly. And do you guys remember what this is? This little aspect here in the X-ray? Yeah, it's a gas bubble, which kind of reaffirms that this might be a PA, because for a PA, the patient has to be standing up. For an AP, usually they slip the backboard in behind and they shoot it while they're in bed, and they may be slumped, and they're usually very, very sick patients. And our patient is very sick, but they may have got that guy up. So this is likely a PA film. All right, let's keep going. And here's Maddie's echo, and we see a few things. So we're looking kind of at an angle where we can see the right atrium, we can see the right ventricle, we can see the left atrium and the left ventricle. And what we're kind of seeing here is we're seeing some hypertrophy of the left ventricle, and that can certainly contribute to a reduced ejection fraction. And what we're seeing here is a reduced ejection fraction. Does anyone know what a normal ejection fraction is? It's okay if you don't. A normal ejection fraction is usually in the ballpark of 50 to 70. So ours is not, super reduced, but it's fairly reduced. When we think of, big ejection fractions, we think of people who are pretty fit, maybe or do a lot of cardio. Athletes have high ejection fractions. When we talk about people who have low ejection fractions, these are heart failure people, heart failure with a reduced ejection fraction. Good question. What causes hypertrophy of the heart? So imagine if Seema, I took you to the gym and I said, Seema, you're going to lift this 25-pound weight. And I don't know if you can do this or not. So this may be, you may be like, yeah, 25 pounds is not that much. But for me, I would be like, oh God, 25 pounds. But so when you're lifting 25 pounds, or we'll make it even more, just in case you can lift 25 pounds. I'm going to hand you a 25-pound dumbbell, and I'm going to tell you to go to the gym every single day. And I'm going to make you do reps of this 50-pound weight. And what we're going to find is what's going to happen to your muscle. Yeah, it's going to build. It's going to hypertrophy. So in this same way, when the heart is exposed to high pressures, when it's exposed to more work, the left ventricle is going to hypertrophy, and that can lead to heart failure. So we see a lot of people of whom are hypertensive have left ventricle hypertrophy. So that's what usually causes the hypertrophy of the heart, is increased work over time. So the heart is a muscle, and it kind of tries to build itself and increase the muscle fibers, the cardiac muscle fibers, in order to contract against higher pressures. Okay, so that's kind of a parallel. Don't skip heart day. That's exactly right. Don't get hypertension. Do cardio, and don't add salt to your food. Those are the life lessons. Don't skip heart day. That's a really funny. Okay. So now what I want you guys to do is to calculate the FeNA. So what we're going to do is we're going to use these values to kind of calculate the FeNA. And I'm definitely going to go over the time, by the way. So if you guys have to go, that's totally fine. I wanted to make sure I touched on the sort of kidney stuff in the beginning, because I didn't want to throw you into this case kind of blind. Okay, so let's calculate this together. And let me move all my things. They're always in the way. All my bars are always in the way. Okay, so this is the kind of formula down here for the FeNA. So FeNA equals urine sodium times serum creatinine over serum sodium times urine creatinine. That probably made you go cross-eyed. The first time I heard it, I went cross-eyed too. So it's just one of those things down the line, you may or may not have to calculate this, but we'll calculate it together. So urine sodium, we see it over here. So 22 times the serum creatinine, 3.3, over the serum sodium times the urine creatinine. All right, and somebody out there with a calculator, what did you get? Yeah, good. Excellent. And reasonably, you can multiply that by 100 and get a percent, but we don't need to, because we know that that number tells us what? It's either greater than 2% or less than 1%, but what is it telling us basically? What is the etiology of this?
It's pre-renal because
Excellent.
a venous growth. Thank you.
Perfect. Yeah, good. So it's definitely pre-renal. Good. And the numbers I made up, so it's probably not perfect, admittedly, but it does point in the direction of a pre-renal. Our history points in the direction of a pre-renal, so good job. And now, what are we saying is on our differential diagnosis? What two things are going on? What are we putting our money on? I will tell you there's two. Good. Heart failure, is there preserved ejection fraction or reduced ejection fraction? There's kind of two flavors of heart failure. And a pre-renal AKI, I like it. Good. Reduced. Good. So the rejection or the ejection fraction was like 44 in the 40s, so it is reduced. Good. And it's causing kind of some of that congestion and correspondingly that hypovolemic state that's causing an AKI. So good. I agree with you. Congestive heart failure with reduced ejection fraction. Let's admit this guy to the CCU, and we're going to give him a few things. So we talked about our Lasix, our furosemide. And that is a loop diuretic that's going to work on remember our ascending loop of Henle. Okay, so things are starting to make sense. It's nice when that happens. Medicine is all connected, and then you'll see in when you get into school that it all kind of helps to kind of make connections to everything. All right, what else are we going to give this guy? We're going to give morphine. That's it may make no sense to you because why are we giving this guy pain meds? But it's a venodilator, and what that's going to do is decrease the afterload, so the resistance that the heart has to pump against, and that's going to help us kind of get more blood to the rest of the body from the heart. We're also going to give nitrates. That's also a venodilator. We're going to give oxygen. That's shown to help. And then position. So we're going to elevate that upper body, and that's going to cause decreased preload, basically. So decreased return to the heart, so we don't get that kind of congestion. We can give dobutamine. That is an ionotrope, which causes increased cardiac contractility and causes vasodilation as well. And then we're going to kind of manage the BP meds as well. Remember that guy is on amlodipine. What was his blood pressure normal, high, low? What do you guys remember? Good. Yeah, it's low. We want to hold that amlodipine. The last thing we want to do when we admit somebody to the hospital is restart a home med when they're hypotensive. We got to look at everything, the big kind of picture here. And one thing that we are going to do when the blood pressure normalizes is potentially start a beta blocker and ACE inhibitor, because these are the drugs that have shown to cause a decreased mortality in heart failure based on these kind of big studies. So beta blockers, those end in olol, so things like metoprolol, bisoprolol, things like that. Those are kind of good drugs to start that are decrease the mortality in heart failure. The other one is ACE inhibitors. Those ones end in pril. Those are the ones that act on ACE, the angiotensin converting enzyme that takes angiotensinogen to angiotensin 1. So things are starting to make sense a little more. Let's clear and keep going. Then the other thing is we want to limit fluid intake, limit salt intake, because remember, what we're talking about is a relative hypervolemic state, but because of the contractility of the heart, the kidney is getting less blood, which is an acute kidney injury. So it's getting less blood. You get an increase in creatinine or decrease in filtration, or a need for dialysis. That's what the acute kidney injury is. That's how we defined it. And then finally, our acute kidney injury, what do we do for that? Nothing special. We kind of treat the underlying cause and then hope that it kind of clears up and we don't have residual effects from that. The kidney is very, very sensitive, you guys are going to find. And a lot of times the injuries to the kidney are not primary. They're because of something else. So, all right. Now let's talk a few minutes about sort of acute kidney injury here. And then I will get you guys going because I know it's late for some of you guys. But what is acute kidney injury? We just kind of talked about it. It's an elevation in the serum creatinine. And it's, I think the standard definition, you'll see it kind of different from place to place. It's like 2 to 3 fold increase in the serum creatinine. A reduction in urine output, so oliguria, so they have a little bit of urine, or the need for dialysis. And that can be hemodialysis or otherwise, or it can be multiple of these things. We kind of went through these things before, but there's kind of a lot of different causes of pre-renal, intrinsic, and post-renal kidney injury in general. So we'll see kind of some of the big ones in terms of pre-renal are going to be kind of this cardiorenal and hepatorenal syndromes. We can see volume depletion. And then when we talk about intrinsic, remember our friends, the medication and our ischemia as well. And then post-renal, we think of obstruction. But here's kind of a big laundry list for you to show that the kidney is very, very sensitive to a lot of different things. So we have to be kind of protective of them, because while we have two, it helps to have two for a lot of reasons. Okay. All right. So how do we sort of diagnose and treat this? Basically, we did what we did before. So we use we can use an algorithm, yeah. So we see kind of this increase in BUN and creatinine. We think, okay, we look at the last values, obviously, and we say, does this patient have oliguria? Are they making urine? That's incredibly important to ask about. If they're not, we're gonna kind of want to think about renal ultrasonography to look at the sort of size of the kidneys, look and see if there's hydronephosis, or see if there is chronic renal failure, which is sort of indicative or indicated or suggested by small kidneys. Okay, but what we're kind of looking at over here is this idea over here is the patient is making urine, and then we get urinary sodium and creatinine levels. And what are we going to see for the FENA in terms of pre-renal disease? Yeah, good. And you guys are definitely going to see that in a few minutes when you do your quiz, but you're going to see a FENA less than 1. And remember, that's our calculation where we have urine and serum, and then serum and urine, and we're calculating all those things. And that's what we kind of come to. So if there's volume depletion, we are going to give them saline. That's simple, right? So if somebody gets in a big car wreck and their volume depleted and then they have acute kidney injury, then we want to give them saline to kind of replace that and kind of help the kidneys, or maybe blood if they need it. If we have CHF, we're giving them diuretics, and we're performing afterload reduction, because what are we doing? We're trying to redistribute that volume to the kidneys. And that's what we did. We gave furosemide, we gave Lasix, and then we gave some drugs, nitrates, and dobutamine, and we gave morphine, things that are venodilators to kind of help the kind of cardiac system in that regard. Okay. This kind of side over here, acute tubular necrosis, allergic interstitial nephritis. We're not really talking about that today, but these are kind of all the intrinsic causes, if you will. Remember, our friends multiple myeloma are here as well, but this might be a story for another day if you guys like the kidney talk. If you don't, then we can kind of save that. You guys could save that for medical school to talk about intrinsic renal failure. All right, I think that's my last slide. That's the last one. And I'm only 6 minutes over. That's shocking. I thought it was going to be a lot longer over. But before you guys go, I want to launch the poll once more to kind of get your guys' feedback on what you learned this evening. All right, perfect. So I'll share the results with you. It looks like most of you guys said you know some now, which is great. None of you said you know nothing, which is always very, very humbling there. And I appreciate your guys' time. Thanks for logging on. I think next week you're talking about like pediatrics or something. You guys probably have the schedule. I kind of am a day by day kind of person, but you guys probably know what you're talking about next week. It's not me. I think I'll be back in 2 weeks. So not next week, the week after, I'll be talking to you guys again. But thank you all for coming. And I certainly appreciate your time, and I hope you guys learned something. I am going to stick around. I'm going to stick around for a little while and answer any questions that you guys have, whether it's about the presentation or whether it's about medical school or anything else. I'll stick around for a little while. But thank you guys again for coming. I appreciate you guys coming and participating. You guys are always a good bunch, I think. All right, we have one question. What do you do if they have a morphine allergy? Admit to the CCU LMNOP section. Yeah, good question. So we can use other venodilators. You don't have to necessarily give morphine. And because we're giving other things like, let's see, let's go back to the slide. Because we're kind of giving other things like nitrates, you know, and other things in combination, it's usually kind of not always indicated. Morphine is one of those things where it's like, some people are like, oh yeah, it works, you know, it's a venal dilator, it decreases afterload. But you know, sometimes some people say it doesn't work. So it's not absolutely. The more important one is kind of the nitrates. That's it's a venodilator, but it's also an arteriodilator. It dilates the arterioles also, so that's a little more important. But you know, we can just kind of leave that out if they have the morphine allergy, as far as I know. Okay, you're allergic to it. Got it. Yeah, well, let's hope you don't have heart failure ever or now. Yeah, can I help with that question? Okay, so good question. Not that I'm saying the question itself is good. Your question is good. Okay, so this guy has a past medical history of BPH. That's benign prostatic hypertrophy. He's presenting with dehydration secondary to vomiting. his bladder is distended, and upon fully catheterization, they get 700 cc's of urine. So we'll go through this together. So he is dehydrated. Yes, he's been vomiting, but his bladder is distended. What's that telling us? He probably hasn't peed, but and then the normal volume that the bladder holds is around 500 cc's. So what is that telling us? He had a distended bladder, and 700 cc's came out. And because the prostate kind of goes through, we talked about it briefly at the beginning. If we talk about the prostate, here's the bladder up here, here's the prostate, and the urethra kind of goes directly through the prostate. So if we start to get hypertrophy of this, it kind of impinges on the urethra. So out of our 3 different causes, remember our pre-renal cause is kind of hypovolemia. Our intrinsic cause is usually things like ischemia and drugs, which he's not on any drugs or anything that would point us in that direction. Yes, he was vomiting secondary to dehydration, but it seems like the bigger cause is this third cause. Do you remember what that one is? And we talked about it kind of being we talked about it being in correspondence, to obstruction. Good. So basically what's happening is because the prostate has kind of hyperplasia, and because those cells are kind of growing and inhibiting upon the urethra, it's causing an obstruction, which is causing an acute kidney injury. Okay, I hope that makes a little more sense. That was a tough one, I thought. That was probably the hardest one because we didn't talk about BPH specifically, but I tried to mention it during the talk, so you guys would have a little bit of information with it.
Can you repeat what BPH is?
Yeah, it's a benign prostatic hyperplasia.
Okay, thanks.
Yeah.
Also, on the same note, the threefold increase in creatinine, I was initially like trying to focus on that phrase, but is that just like fluff, or can that also help you?
That can, because that's what's telling you that it is an AKI. So basically remember, let me get to the slide. This one, an elevation in serum creatinine level, and usually that kind of cutoff where we say it's significant to be an AKI is 2 to 3-fold. Okay, so that kind of tells us that that it is in fact an AKI. And yes, I told you in the question that it is an AKI, but I wanted to kind of put that in to get you thinking AKI before I even told it. Okay.
Yeah, and sorry, one more question. What is ATN?
Yeah, so that's acute tubular necrosis. So if we go to kind of, let me clear that. If we look at this intrinsic pathway, that was kind of a distractor question. And when in doubt, if you don't know what the thing is, it's probably not that. But a lot of people will choose it because they're like, oh my God, it must be that. I know what these other ones are. But if we get a problem with the tubules in the interstitium, that's usually acute tubular necrosis. And what we see is kind of sloughing of the tubular cells. So we see renal tubular epithelial cells in urine, and it's just kind of damage to the actual tubules themselves because of various causes. But yeah, that's what that is. It's kind of a whole talk on its own.